I wanted to re-welcome everybody to our webinar. We'll go ahead and get started, and I would like to have everyone who's joined us in our office here to introduce yourself real quick, and then we'll get started with the presentation. So go ahead.
Good morning, everyone. This is Molly Antonello with the long-term care team.
Hi, my name is David Chadwick, Health Program Manager 2, if you're wondering what HPM stands for. It was one of the questions, so.
My name is Geeta Samuel. I'm the nurse with long-term care authorization in PASRR.
Hi, my name is Alyssa Bowden, and I'm a Health Program Manager 1 with long-term care.
I'm Lisa Labady. I'm an OA2.
Okay, thanks everybody. Should I go ahead and start our first?
Yeah.
Go past. Okay. Let's see. All right.
All right, so we're going to go over the agenda. We're going to start off with the Senior and Disability Services website and guidance, where we'll show you how to navigate to everything. And then we're going to go to the processing numbers for August and September 2017, so we can show you how many complete and incomplete PASRRs and long-term care forms that we've had. We're also going to go over the skilled nursing facility and intermediate care facility level of care changes, regulations spotlight, and then overview of senior and disability services that we offer. So this is the Senior and Disability Services website, and if you just go to Google and put in Senior and Disability Services, it should most likely pop up. For long-term care and PASRR resources, on the right-hand side of the website under Programs and Offices, you're going to find the long-term care and PASRR resources. And that's the one that you're going to want to click on, and you'll be able to find the long-term care and PASRR forms, the most updated ones, as well as any information from webinars and things like that. All right, so now we're going to go over the submission tracking, which you'll be able to see how many PASRRs and long-term care forms that we process based off of August and September. So for initial authorizations and PASRRs, we have processed 42 ICF initials, 71 SNF initials, 18 swing bed initials, 8 AWD initials, and as you can see, the most that we've processed in 2 months is 229 PASRRs. We've gotten 6 PASRR Level 2s for Department of Behavioral Health referrals, and then we've only gotten 1 PASRR Level 2 for IDD. And this just shows you how many incomplete PASRRs and initials that we've had. For ICF, we have 11 incomplete. SNF, we have 37 incomplete. AWD, we have 8 incomplete, and PASRR incomplete, we have 42. And what makes it incomplete is when something is missing on the form, such as a signature or a diagnosis or things like that. And this just shows you a chart of the incomplete versus complete. So for PASRRs, it looks like we've done 229, incomplete is 43, so percentage of incomplete is 19%. So that's not too bad. For ICF, complete is 40, incomplete is 11, and so the percentage is 27.5%. For SNF, 72 have been complete, 23 have been marked incomplete, so that puts it at 32%. Swing bed, you guys did great. We didn't have any incomplete, so good job on that. AWD was the most incomplete, so we have a little more work to do on that. So, and if you need any guidance on that, feel free to call us and we can walk you through the forms or any questions you have on that. For the reauthorizations, we've processed 158 for ICF for August and September. SNF reauthorizations, we've processed 38. Swing bed, we've processed 7, and AWD reauth, we've processed 1. Incomplete, we've had 24 ICF reauthorizations incomplete, SNF reauth incomplete 8, and swing beds 0 incomplete, and AWD 0 incomplete. So good job on that. And this just shows a chart of complete versus incomplete for reauthorizations. For ICF, 157 complete, incomplete 23, so it puts it at 14% incomplete. SNF complete was 35, incomplete was 8, and then percentage incomplete was 22%, and then again for swing bed and AWD reauthorization submissions, it was incomplete. And David, why were they marked incomplete?
Could be a multitude of different reasons. Sometimes it's missing a signature. Sometimes it's as simple as we're missing the medical reason for continued placement. Other times it can be the form is all filled out, but whoever did the form didn't sign their name on it, which is what we mean usually by the signature. You know, a lot of times there is some information that we can assist with, like the dates. If it's just a rounding issue where, you know, we put February 31st on there instead of February 28th as the end date, you know, we can usually correct something as simple like that. But there are other times when we have ICD-9 codes instead of ICD-10 codes where we will need the facility to take and correct those. So things like that, you know, if we can help you with it, we're not going to take and say that it's incomplete, and we will usually take and send it back to you. So those are the reasons that we usually will run into with reauthorizations. Reauthorizations tend to be a little bit more routine because we do process more of them, especially when they're, you know, patients have been there for years a lot of times. So we will see a lot of the same information. I do ask though, we have been seeing some of this where if we have an old correction that may have been put in by hand and then we kind of repeat on the same form. So, you know, the existing long-term care form went in, became effective in November of 2016. So this might be the third go around for the use of that form. And for a lot of times, you know, nothing has really changed about the patient, so we're using the same information over and over again. But that handwritten correction may have to be sent back 3 different times, you know, 6 months apart, because we've missed the same, you know, correction all 3 times. So, you know, if we're gonna ask for a correction, please make it on the original.
Question says, once a form is completed with the additional information, is it moved to the complete column, or is the complete form still just hanging out there incomplete? Basically, what do we do if it's found incomplete?
Send it back to the facility, and then we update it as complete when it comes back in.
And we won't process it until it's complete. So if you're waiting for an LTC or PASRR, the reason you're most likely waiting is because it's still incomplete and we're waiting on the correction. So the faster you get them corrected, the faster we can process.
So I'm sure that everybody knows about the PASRR, but there are a few people who are new. So we'll just go over like a fast review for the new people. So PASRR is the pre-admission screening and resident review. So SDS is responsible for oversight of state PASRR process, which requires that each individual, regardless of payment source, be screened for diagnosis of or indicators of mental illness, intellectual disability, or related condition prior to long-term care facility placement. to ensure that the placement is appropriate to the individual needs. So even when admissions happen from home or from the community, PASRR should be done. And I know that all of you know that the surveyors, when they come for the inspections, they go over the PASRR, and sometimes they call here also. If they are not there, they will get us, send the PASRR to the facility or to them. So that is what it is. And federal PASRR regulations, you have that on the website, and the PASRR regulations federal is 42 CFR 483 subpart C, and it is actually from 483.100 to 483.138. I'm just telling that from the website. So in that, if you see in 483.112, we have like two subdivisions. That is, one is determination of need for nursing facility services. For each nursing facility applicant with MI or MR, the state mental health or intellectual disability authority must determine in accordance with the regulation 483.130 whether, because the resident's physical and mental condition, the individual requires the level of services provided by a nursing facility. So first one is it should be determined that the person needs nursing facility services. And the second one, if the person has a mental illness or intellectual disability or related conditions, there should be a determination of need for specialized services. So that is what the second requirement is. Then the timeliness, that is the level 2, actually the process takes average of 7 to 9 working days. And before, I think from my start, maybe it's like before, maybe like 10 months before, it took a long time. But right now, the Division of Behavioral Health people are really working hard to actually contract with the contractors in different areas according to the locations, and they're trying to get this done within this time range, 7 to 9 days. So that is the federal PASRR regulations, and you could actually see that in the website. Next one is PASRR process consists of level 1 screening and a level 2 evaluation. So level 1 screening, there is like a PASRR form on the SDS website, which all of you know. And for the new people, it's like it's on the website. There is a PASRR form and a long-term care authorization form. So you could fill that out and then submit that through DSM. So that is the level 1 screening, and it should be submitted prior to admission regardless of payment source. And it must be also submitted when a resident experiences a change of condition that identifies a new diagnosis or of indicators of mental health. That is called the resident review, because in the PASRR, it's like pre-admission screening and resident review. So the resident review is actually on the page 1 of the PASRR on the right-hand corner at the bottom. It is written that if the person actually experiences a significant change, for example, the LOC is changed from SNF to ICF, or the condition declines from the person was from ICF and then the person moves to SNF, or there is a new PASRR related diagnosis of mental illness or any indicators of mental illness, then you can actually send the resident review form, and it will be reviewed by the long-term care team and the nurse, and then we will send that to the Division of Behavioral Health if it is needed. Then the level 2 evaluation is conducted by Division of Behavioral Health contractors, and also if there is an IDD problem, it will be done by SDS IDD staff for intellectual development disabilities or related conditions. And just to let you know, the related conditions are like 7 of them. It is like cerebral palsy, autism, Down syndrome, muscular dystrophy, and TBI, seizure, and fetal alcohol syndrome. It's all in actually the PASRR resources in the website. So if you have any questions, you are always welcome to call us and we would help you out. Then the next one. Okay, so this is a little overview of the PASRR level 2 process. The step 1 is the PASRR is reviewed by the LTC team, And then if there is any mental illness or intellectual disability or related conditions identified, then we have to send it for a level 2. So we will send the level 2 to IDD or the Division of Behavioral Health. So the next step 4, if a level 2 evaluation has to be done, we have to send a notice of the level 2 evaluation process to the client or the representative as well as to the hospital. So you know that when we look at the form, we always ask you about is there a person for the decision maker, POA, surrogate decision maker, or OPA guardian. So that is the reason we are asking, because otherwise we wouldn't know where to send the notice to. And step 5 is the DBH or IDD department has an average of 7 to 9 working days to complete the evaluation. And usually when we send the thing for the level 2, we send you the LTC form back to you, the facility, telling that it is in pending status. So please don't admit the patients to the long-term care. If the patient is in the hospital and they are going for a level 2, the person should stay in the hospital until a level 2 is all completed and the report obtained by the facility. Otherwise, there will be problems with your payment if you admit the patient before the report is obtained. Step 6 is once the level 2 results have been received, the LTC and PASRR can then be processed, and the notices are again sent to the patient that level 2 is done, finished, and the report, we will send it to the people. So
this is Kara. I just wanted to jump in. A couple of us have asked about the PowerPoint. I just wanted to let you know that if you look for handouts in your webinar display, you can actually download them. Your device has to be able to view PDF files. If you're watching us on a phone, a lot of times our smartphones don't have a PDF capability. Most of our computers do. It kind of comes with it because it's a real common file format. But you can certainly download this presentation and any other presentation we share with you today. If you have trouble downloading it, just write us a quick note in the comments that you would like it to be emailed to you, and I would be happy to email it to you. Okay?
So one more additional thing I will actually add is you will also see the abbreviated PASRR level report, because when you use the PASRR categorical determinations, that is when I write a PASRR level 2 abbreviated report. And the PASRR determinations will be always on page 4 of the PASRR form. And you can actually check the PASRR determinations when the form comes to you. And if you have any questions, you are always welcome to call and clarify. Okay, next one is we will actually go to skilled nursing facility services and intermediate care facility services. So in the regulation, it is on our website. There is 7 AAC 140.500 to, I think it is 585. The whole regulations are there. So in that, the skilled nursing facility services is 7 AAC 140.515, and intermediate care facility regulation is 7 AAC 140.510. So we have actually provided you with a nursing facility level of care crosswalk. So you can also actually refer that if you want along with this one. So if you see, the skilled nursing facility level of care is needed to treat an unstable condition, whether the ICF is for treating a stable condition. And both are ordered by and directed by the physician, and the physician order required for skilled facility services, the person should have at least 5 days of PT, or there can be OT, speech therapy, wound therapy, all those stuff is there, and the form has all those components. You can add everything on the form. Then there is ongoing assessment of rehab, structured rehab for skilled, and also for ICF, there are therapies which has to be done by the therapist. And I can tell you just few things from the crosswalk. So the skilled nursing facility services is needed to treat unstable condition. For example, like if the person goes to the hospital, they get admitted to the ICU, then they come out to the floor. That means that critical stage is passed and the patient is like still unstable because if the person had a massive stroke, the person has real difficulty affecting, like, the sides is affected, whichever side the person cannot talk, and the person's level of mentation could be different. So that is considered like an unstable condition. So, and then in the intermediate care facility, the thing is the service requirements is needed to treat a stable condition, and it is ordered by the physician. And in the services for skilled nursing facility services, the nursing services are the observation, assessment, it's there. Services are the observation, assessment, and treatment of recipients on stable condition. That means the nurse is there required more frequently to do the assessments and treat them. And for intermediate care facility services, it is the condition is relatively stable, and the emphasis is on maintenance rather than rehabilitation. And the nurses are needed there, but maybe not that frequently as you did for skilled level of care. Then in the services, it is the same thing again. It is like the structural rehab services, which is like PT, OT, speech, 5 days or 7 days. But with the intermediate care, it can be, the therapies could be 3 days. And it should be performed under the supervision of a physician, supervision of a qualified physical therapist or occupational therapist. So, and also there can be all like additional procedures, treatments, wound wax in the skilled therapies. And the intermediate care facility services are like, again, it is like a stable, the patient is stable, so it is maintenance, that is the emphasis on maintenance rather than rehabilitation. You could go through that crosswalk, and always if you have any questions, you can actually call us and talk to us. And we actually, when I discuss skilled and intermediate, I have my manager and I have other supervisors and nursing supervisors, which we actually consult. So it's like a little team of people we consult. Okay, so I think if you have any questions, you could ask me at the end. So let me see. And okay, one more thing. Next slide, okay. Maybe we can go to, and then we can
go to the next one.
Yeah.
All right.
Yeah, we already covered that. Okay, so the thing is, when you send all the forms, the long-term care authorization forms for renewal for SNF, for ICF, you give us the whatever information you have, and make sure that you write in detail on the discharge sections why you think the person meets skilled level of care, or why you think the person meets ICF level of care. And if you have records with any level of care change or the patient's condition, please send us whatever records. And you know the patients better than us, so it is better for you to do the decision rather than us making the decision for you. And you can always call for assistance or help. And additional medical documentation, I know that so many facilities have told that we are asking for so many records, but this is all done to help you out, like to help the facilities out, and to make the right decisions first for the client. And then we have to use our critical thinking and judgment. When we see all these notes, we have to review everything before a final determination is made. It is all for our clients. So we need that. Can I just have the slide one more time? So basically, we are asking for H&P if you have one, or the doctor's visit notes. Maybe the doctor comes like once in 3 months or something. If you could send us that, we can look at that. And if there's like a plan of care or a care plan which you're using, and your IDT notes is really a very good source for information, because we have seen that in the past, the IDT notes gave us so many information for which helped us to determine the level of care for patients. And the discharge planning section, again, write it detailed. And from the discharge planning section, if you really make that points there, for example, if the person needs like PT 5 days, 7 days, patient has a wound vac, the patient is IV antibiotic for 6 weeks going, and the patient has a central line, the patient has G-tube, and the patient's condition is unstable or stable, whatever you have to write there. And if the person needs really extensive assistance, you can write everything there so that it could be a real help to our team. Notes to support change in condition or continued stay. Okay, so this one we could look at an example on one case. This form was sent to SDS. SDS is Senior and Disability Services. That is our office. That's why sometimes we write SDS. So it was sent, and this person's diagnosis, admitting diagnosis, was unspecified intracranial injury and unspecified mental disorders due to known physiological condition, and it was epilepsy, unspecified, not intractable, without status epilepticus. Other symptoms involve appearance, behavior, benign prostatic hypertrophy without lower urinary tract symptoms. So then the level of care was ICF. Medical reason was like TBI, poor memory, seizures, psychological behavior monitoring. The next one, please, the next slide. So if you see the medications, there is like anticonvulsants, Keppra, Lamictal, and tamsulosin for the bladder, and Celexa, Prozac for depression and everything. So that was the medications, which was like the patient was getting scheduled medications, BID, for seizure disorder. Next slide, please. Yes. Then if we go through the ADL, self-performance and support score, you could see that the scores are all scored like 0 or 1, which is like really independent, and supervision. And short-term memory, they wrote like late effects of TBI. So when you look at this form, this form actually, and there was no therapies, no PT, no OT, no speech, and the level of care was written as ICF. So if you look at the form, in the first place, and if there is no records, it looks like this person is stable. And discharge instructions, actually, we didn't put it there. It was not that great, so we didn't put it there. So when SDS was reviewing this, the client actually did not meet the ICF level of care because there's no PT. ADL assistance was really scored 0. And when we look at this one, we think that, okay, if this person has a problem, then the person could actually have a waiver assessment done. And there are other services which SDS provides. So we were thinking about that. But even before actually making a real determination, we actually have our team which looks at the case, and we are like, this person is not meeting level of care. So I actually emailed the facility asking for more records. So I asked them, whatever records could support your ICF level of care from your side, because you are the people who come in contact with the patient more than what we are. So we asked the records. And I think it was like 2-3 months time duration. The email went, and you were sending me records. The first one, like they sent me PT-OT records, which indicated that the person was having, not PT, sorry, it was OT. So the person was having some OT time with the occupational therapist, which was not very significant. Then they sent me doctor's notes, which was not really having anything. Then we asked them, the facility, whether the person has any seizure activity going. Then they were trying to look through all these notes. They couldn't find anything. Then at last, what happened was the facility sent us some IDT notes. So the IDT notes actually documented seizures. The person was having seizure, the person had seizure, had a fall, went to the ER, then the family took this patient home, the patient was having seizures again, the patient was brought by emergency ambulance to the ER. So when we saw that IDT notes, we found that the patient, even though the person was having all the scores, the person still had problems and was meeting the ICF criteria based on the seizure problem. So that is why we ask all the records. It is not to annoy you, or, we know that you're so busy there, and we understand because we all worked in your field before we came to this job. So please, have patience with us and help us out. And even without asking all these things, if you can send us the forms, whatever, which will help us to make the decision like faster, that would be great. You can send us the form. So this patient actually met the ICF criteria after getting the records, and we had to really dig through all those notes and find the ICF criteria. So that was one of our examples which we wanted to show you.
So Kara, this is Molly. If we could just go back to a couple slides there. And I just want to point out that, you know, we try to find the information as much as we can by reading the info you've provided. And so if looking at this slide, and if you look at medical reason for admission or continued stay, it's listed as TBI, poor memory, seizures, psychological behavior monitoring. None of those things would automatically put someone in a nursing home. Those diagnoses or symptoms provide only a limited amount of information for us to consider. Not apparent for TBI, not apparent for poor memory, psychological behavior monitoring. What stood out was more the seizures than anything else. So a little more detailed information in that section would definitely help. And like Gita said, in the discharge plan section, you could add additional detailed information to lead us to where you're finding the need. So here in this ICF level of care, we see that it's the need for that continuous observation, assessment, and treatment. So here it's apparent that after review of the medical documentation, a nurse needs to monitor, you know, especially when a seizure does occur, and come to that judgment or that critical, or make that critical judgment to call the doc and to report, you know, something that needs to be reported to the doctor, and possibly get an order to start a different medication or to change a medication. This is where that observation, assessment, and treatment comes in. So this identified clearly with ICF versus skilled nursing facility services. So yes, we may be asking for a lot of different types of records, but until we find something we can use to make a little more sense of what level of care and why the person needs to be in a nursing home, we may not be specifically asking for a type of record. We may still be looking. So we do look to you to provide us with that type of information. Give us a little more detail on the application, and then records to support it really does help. So I just wanted to add that to Gita's.
I have one more thing. IDT stands for interdisciplinary team. That is a team in the facility with the doctors, therapists, nurses, and who all are participating in the care of the patient. And I could see that when we asked for the determination part, the IDT team actually made the same decisions, whatever like we were seeing in most cases. So we didn't have a conflict until this point with the facilities. Whatever like they are telling us, they are not meeting level of care, we found the same thing, that the patient was not meeting level of care. Or when we questioned them about the level of care, IDT meeting was called in the facility, and they found that the patient was not meeting level of care. So anything, we will always work with the facilities because this is for the client's benefit. That's it for me.
Just to add one additional piece, a lot of times facilities will tell us that the way that the form is currently set up, that medical reason for admission section does not allow for a whole lot of explanation outside of you know, a real simple statement. But we do want you to feel comfortable adding an additional, I mean, if you have to add an additional page on to the end of the form that says that, you know, if it says see attached, and you give us a good paragraph there that says that this person has unstable seizures, they have additional problems that, you know, we need to expand on and can't just explain in that little section, you please do that. Please feel comfortable doing that. We want you to feel like the more information that you give us, the better.
Okay. Do you want to take any questions at this time, or do you want to keep going? It's up to you.
I think we can take a couple questions now while we...
Okay. Okay, so question says, SDS has asked those who are filling in forms to fill in every blank. Example says, when I type up the LTCA, I fill in the admitting diagnosis boxes and copy the same into the discharge diagnosis. I see on this form the discharge diagnosis is empty. Is it okay to leave it empty? I think they were looking at the example, and you'll have to tell me where that is. Here.
So this page, so this person, I believe this was a re-auth.
Yeah.
Right. So they weren't specifically looking at discharge or a possible discharge. This will most likely be an authorization that may come from the hospital. So if the hospital is admitting someone, you'll see most likely an admitting diagnosis, and then a discharge diagnosis specific to the hospital discharging. So we may not always see it here, especially on reauthorizations. It really depends on the placement and what the request is for. Continued stay, initial, level of care change. So
a couple of us had that question. When is it appropriate to leave it blank, or when is it appropriate to fill it in? So I think you kind of got it.
Yeah, the rule of thumb is, you know, try not to leave anything blank. But, you know, in this case, what Molly said about the admitting and discharging diagnosis is.
Okay. Any other questions? It says, so on a new submission, do we fill it in or no?
On a new submission, on an initial admission, so coming from either the hospital to the nursing home, I would expect to see that there's a discharge diagnosis from the hospital and admitting diagnosis to the nursing home. It's coming from the hospital, but here is where there is an expectation that, it is an expectation that they're discharging from one place and being admitted to another. So it'll always be appropriate to have a discharging diagnosis. But if the person is coming from home, I won't expect to see anything there unless there is something the physician might want to include there. Maybe they had discharged from the hospital, you know, a week ago, you know, and the doc wants that reflected on, you know, that's always appropriate, always appropriate.
Question says, for ADL of self-performance, why is the look back 7 days? I don't understand why we're not looking at a bigger picture, because people's abilities often fluctuate.
So if you want to go to the next slide, to that section, the next one. So the look back is 7 days, and 7 days is, this comes directly out of our consumer assessment tool, which is the assessment tool we use to assess for nursing facility level of care. And then there is a choice as to whether the applicant wants to choose home, to remain living at home with home and community-based services, or I should say, rather than institutional care. This is the time frame identified on the assessment tool, which is a tool that was, you know, derived from the MDS. The 7-day look back is another way of looking at the creation of or the development of services looking ahead. So it's specific to 7 days. It's more a snapshot in time of what the needs were for anyone who's applying. We do have specific criteria around the 7 days if they're at home, or 24 to 48 hours if the person was in the hospital. So while it's only looking at 7 days, there is no prohibition of including additional information that might look beyond 7 days. You're more than welcome to submit documentation that looks at time for beyond or outside of the 7 days indicated here. This is more a snapshot of that time. So when you fill this out and you send it in, and someone might meet level of care today for the day you're filling it out and sending it in, they may not meet the same level of care a month from today. So, you know, the look back is 7 days only. It's just a period for consideration, not that we will not look at anything beyond the 7 days.
Okay, thank you, Molly. I don't see any other questions right now coming in, so we can go to our next section, but I did want to let everybody know that there's a comment offered which says your program, I'd like to say your program has developed and improved, and the processes have improved, and you guys are doing a great job.
Awesome, thank
So
you.
thank you. We love to hear compliments.
Yes,
We're trying.
We are trying. You're reaching out and doing things new and better. So,
all right. So we have 3 regulation spotlights this month. They're all repeats of things that we have gone over before, but we do like to reiterate and refresh on these. So the first one here is our transfer of recipients. And if you want to go to the next slide here, the most important aspect of this regulation that we use most frequently is related to the level of care change. And you'll see right at the top there, it says no later than 7 days after a nursing facility transfers a recipient to another level of care within the same facility, facility must notify the department of the transfer by submitting the current request on a level of care authorization form provided by the department. So for us, that means our long-term care form. And it either needs to be signed by the physician within that 7-day period, or we want a physician order from that time period within 7 days that it has been, the level of care change has been made, because we do require the physician to be the one who makes the level of care change. And this can be noted in additional documentation that can be sent to us, but the easiest way to take and confirm this and to avoid any difficulty is by sending us the physician order or a signed long-term care form, you know, that has been signed in that time period. The level of care change, like any other authorization, always requires the long-term care facility authorization request. But we're just, these are the things that we look at when we're looking for that, you know, what is it that caused that level of care change and what's going on with that. And so if you'll see on the next slide here, these are the things that we're looking for to kind of confirm that information. You know, we want it, you know, it must be signed by the physician. We're looking at you to take and identify, has the condition declined, has the condition improved? We're looking in the discharge plan for some information as to what's going on with the patient. What caused the level of care change? You know, have they had a recent problem where they now need to have PTOT now 5 days a week instead of 2? And also, you know, we want a little bit more information identified in that medical reason for continued stay and things of that sort. And like we said, you know, you can attach another page if you want additional room to highlight, you know, what's been happening. And we do recognize that, you know, it is often difficult to meet the 7-day requirement. That's why we, you know, we will work with facilities, and, you know, we will move heaven and earth to try and help you out with things of that sort. But really what we're looking at is we're looking for the medical documentation and the level of care change form to identify what's happened. If you send me a level of care change 3 months after it happened and don't give me any information, it's really difficult for me to take and go back and figure out what's happened if I don't have any documentation. So that's, you know, that's what we're working with, and especially why we will ask for additional medical documentation when we do. A
couple questions. I think you just answered the first one there. Does the level of care paperwork need to be completed for patients who went into acute care for only 24 hours?
No.
Are you talking about a patient who goes to a hospital and then they come back from the hospital under a different level of care than they went into the hospital? Because I could see in a situation that in that situation where if the patient is coming back from the hospital as a different level of care, then we would need the level of care change.
Oh, I see what you mean. Okay. So maybe they were in the nursing home under ICF, and they, suffered a change in condition and had to be admitted to the hospital, and now coming back from the hospital to the nursing home, their level of care may have went up from ICF to SNF, or, okay, yeah, then yes, absolutely. I wasn't thinking of it from David's perspective, but yes, I see that now.
But if there's other situations where if they go to the hospital because they've got some shortness of breath and then they come back as the exact same level of care, we're not going to ask for any changes in that sense.
Okay. Okay. I think we got that question. Feel free to, of course, write in additional questions as we go here. We do have until 11:30, so I would suggest to just go for this next section.
So the next one here is our planned absence from a nursing facility. We do get a lot of questions about this particular regulation, and so the idea behind this is that it's planned and temporary. This is, not more than 12 consecutive days. We want to make sure that it's recorded both by your records and by the information that you send us. But we will pay for reserving the bed. And these things include, visiting relatives or friends. Let's say they want to take and have Thanksgiving at home to meet their new granddaughter. Well, yeah, we absolutely want them to take and be in a situation where they can be with their family. Leave to participate in therapeutic or rehabilitative programs. If there is a brand new program in Seattle that lasts a week and may actually have some positive benefits for the person, if they're going to plan it and they want to take and do that and write it into the care plan, then we can work with you. Trial visits at alternative care settings. This is really important. If you have a patient who is borderline and trying to get out of the nursing facility and go to an assisted living home, and you want to trial a stay at an assisted living home to see how they do, this is exactly the kind of situation that we're looking to facilitate. And these visits are to prepare recipients to return home to the community, or even things like an extended absence to participate in a workshop evaluation, things of that sort. So next slide. So in this sense, the department will not pay for reserving a bed during the temporary absence of more than 12 consecutive days unless the department gives prior authorization for the absence. So basically, we want to know beforehand. And what we're asking in this sense is we're asking for something on the letterhead from the nursing facility and a care plan note. So this is basically saying it's identifying that you as the nursing facility have worked out an agreement with the patient that you're going to send them to this rehabilitative program, or we're going to trial them at a local assisted living home, and it's in the care plan and everybody's agreed to it, and then we're going to work with you, because if it lasts 12 days, we're gonna work with you. If it's the second 12-day period in the last year, because you've planned it out beforehand, because you've contacted us and involved us in the process, we are happy to take and work with that, because we want to, we don't want nursing facilities to be dumping grounds for people to just stay there for the rest of their life. We want them to come in and get the treatment that they can, and if they are able to go back into the community, we want that to be an avenue for them.
And so I just wanted to add that we don't see very many requests for this. But, it is available, for those. I will say that we have had prior unsuccessful transitions from nursing home to home or community living, just because, you know, you can't foresee everything that might happen. But, you know, this is one way we see, like David said, an avenue to for the state to help, for SDS to help facilitate some of these trial transitions before it becomes a true discharge. So, you know, we can look at a seamless and much more successful transitions out of a nursing home and into the home community. So let us know if this is something that I know. I've heard from other facilities that because they do have all three entities, it's probably easier for them versus other hospitals and nursing homes. But at any rate, it's there, it's available. You know, we, like David said, we'll definitely work with the nursing homes to help facilitate this.
So facility must submit a request in writing, and like I said, it's something that comes from the facility. It's an agreement that's worked out with the patient as well. And then, you know, we want a plan of care note, something that tells us, you know, what the therapeutic or rehabilitative absence is for. If it's for the community placement as an alternative care setting, that's fantastic. And, you know, we want that worked out with between the patient and the care team. If they leave the nursing facility for hospitalization, that's not what we consider this to be a part of, because usually if it's for hospitalization, that's more of an acute environment as opposed to a pre-planned type of arrangement. The next one here, do we want to answer questions or do we want to?
You have 13 more slides left, and what's our time check here?
30 minutes.
Okay, my best suggestion is we could do a couple and then we'll be able to get to the end.
The next set of slides, they're fairly quick.
Okay. A couple of questions here. If a patient is needing wound care twice a day, is that marked as part of PT orders? Where does the need for wound care need to be indicated on the LTCA? For this example, the hospital wound care is done by PT department.
There is another section on the long-term care form where you can select other and then write in what type of therapy is being provided. That can be entered, and it can be wound care, things of that sort.
Yeah, treatment.
Yeah.
Different types of treatment if it's not wound care.
Okay. Do we submit a level of care change if a resident discharges from the facility to the hospital while under Medicaid, ICF, then returns to the facility under NCR for a 5-day period? Medicare. Okay.
The payment source is not. The payment source for us is not really tied to the level of care. Like, we don't. The level of care is the level of care that they're receiving, not who is paying for the service, if that makes sense. If Medicare is only going to pay for it under SNF, and so they go in under SNF Medicaid and come back SNF Medicare, you know, we wouldn't request a level of care change because their level of care didn't change. It's just a payment source.
Okay. Regarding the absences we were just talking about, are the 12 days for any reason? Also, can we speak to transferring from a swing bed SNF level of care to an ICF level of care? What would we check?
Yeah, you would check. I mean, it would still be a long-term care form, and you would check that you're going from SNF to ICF, or whether it's ICF to SNF. Although it'll still remain a swing bed. There's no difference there.
Are the 12 days for any reason?
Well, the 12 days for, if you go back to the slide there, it lists all the different reasons that it includes there. I'm sure it's not going to list every every one that someone might consider using, but it sounds like most commonly it's visit with relatives and friends that is most commonly used.
Question says 12 days out of facility in 1 year. Are we obligated to keep a bed beyond that?
No, not necessarily. You're not obligated to keep a bed beyond that. That's really up to the facility and really, you know, depending on what the reason for the absence is, that would definitely be on the facility.
Okay.
I'm going to answer the next question. If it is the 12 days of Christmas, that works. Just let us know about it.
You never know.
So with the last one here is the discharge of recipients. We'll go through this one. This one we have done the last 2 webinars. Go to the next slide here. But this is, you know, appropriate notification to SDS and to the patient when the facility initiates a discharge. We want to know at least 10 days before that date of discharge. And so a lot of times we get a facility-initiated discharge with a 30 days, saying that the patient's going to be discharged from the facility in 30 days. If you're going through that process with a patient, we want to take and know about it. We want to see that notice. And that's what this regulation, you know, is giving us access to. So go to the next slide. So, you know, we want to know, because it is required to be sent to SDS. It's important for us to be able to take in and start looking at how we can help you with alternative resources, especially with our nursing facility transition grants, especially with waiver and PCA type services if they're going to go directly back into the community. And we can start working with you as far as, you know, finding care coordinators, getting in contact with the ADRC, or Adult Disability Resource Center. And so, you know, when we get that information, you know, it usually is going to come to us in our long-term care box. And that way we have an idea of, you know, what the plan is for the patient. And we're happy to help start with that transition and discharge. So speaking of that, we're happy to take and walk you through some of the other additional resources that we have, which is, again, the ADRC, the Adult Disability Resource Center. This is kind of our clearinghouse for where we like to, you know, send patients and representatives at the very first chance that we get. This is a pilot program that is now turned into, this is the official way that we want to do it, because it really does streamline the eligibility. It gets people in contact with the experts that know what the additional resources are.
And most importantly, this is where people are provided with options. This is where you are provided with all different types of resources. You have the ADRC representative will provide options counseling and go over some of the questions you might have. That maybe these aren't the services that you want, maybe you're looking for something else, or maybe you don't know that something else exists that you might want to consider. So we like for everyone to make an informed decision. This is the person-centeredness of our programs, and we want for everyone to fully understand what they're choosing. You know, while the audience here is nursing homes, also understand that you have a choice to receive home and community-based services, you know, in your community rather than nursing home placement. So we just like for people to know that there are options out there for you to consider. The Aging and Disability Resource Center is the center, is the place to go. You know, whether you call, whether you go to their website, this is a good place to receive that options counseling. You'll be better equipped to make an informed decision about what options you have and what options that you might not have. So we always like for people to go here just to know what's available. And, and if you don't find it there and these services are what you're looking for, then good. And it is a Centers for Medicare and Medicaid initiative that we are very person-centered in our processes, and we like for people to understand what they have and what decisions they're making for themselves. So always a good resource here.
So the next part here is an overview of SDS services, the types of home and community-based waivers that we provide, as well as personal care services. So our home and community-based waivers are where we want patients to have a choice to receive home and community-based care rather than care in a facility or institution. We have 4 different types of waivers. Alaskans living independently, what is it?
Adult with physical and developmental disabilities.
Sorry, I was calling it Adult Disability Resource Center before, and it's Aging Resource Center. So I'm a little bit wary on all of my acronyms now.
Adults with physical and developmental disabilities, children with complex medical conditions, and intellectual and developmental disabilities.
Next one.
There you go.
Yeah, so here they are. Here's all 4 that we provide. Like we just said. So we can move to the next slide after this. So all of this information will be available for you, on download so that you can have access to it.
And people can choose to receive, people who meet level of care, such as that provided in a nursing facility or intermediate care facility, can choose to receive that care, their care in the home and or community. But it doesn't mean that, an assisted living home is the same as a nursing home at all. It just means that people will receive care from the waiver approved certified providers who do have credentials and the ability to provide care. But if they need skilled care, they're still going to get it from a skilled professional, but through the care of the home, and they'll go to the clinic for that care and things like that.
Right. So an example I can think of is someone who needs physical therapy 3 times a week. In an assisted living home, the physical therapist may be going to the ALH to provide that service to the recipient, to the applicant, excuse me. So different situations and different needs can be met in different ways. This is just an option that's available.
So one of the things that we do is that when we are considering doing an assessment in a nursing facility to set up the assessment for these services, to find out what kind of services and options that we would provide to a patient. This is our CAT intake and assessment unit discharge plan summary template. And so this is the type of information that is going to be asked of the nursing facility and care coordinator to take and collect before we are able to take and go out and have the assessment in the facility. I'll like Geeta to kind of explain this a little bit more.
Yeah, discharge plan summary template is like, we have the other supervisor, Ms. Paula Rave, who is in charge of the waiver unit. So actually, LTCA, our unit, and waiver unit could work together and help the facilities with all the discharges from whichever areas you need help. You let us know and we will help you. And most of the information for this, we could also use it from the long-term care information what you already have provided. So you can provide the rest of the information. For example, if the person is receiving therapies and you have the therapy notes updated to that day whenever the assessment has to take place. So please provide all the information on this template. If you have any questions, please call me and I will be able to help you.
Right. This is just some guidance as to the type of information we're looking for. So if you're looking at a discharge and you're applying for waiver or PCA, this is the type of information we'd be looking for in order to agree to have an assessment conducted while the person is still either in the hospital or in the nursing home. So we have a little more, so like Ida said, we may have a lot of this information already because you provided it with your long-term care authorization form, or just as part of some records that may have been submitted to us, that can easily be available to the assessor who may be, getting ready to come out and do an assessment, for her to review or for him to review and make some determinations and look at special or identify some focus and emphasis for the assessment prior to the actual day they might travel out there to do the assessment.
And we are so thankful because all the staff in most of the facilities, they really participated with all these things, and we really appreciate what you do. We know that you have a tough job there, and but in spite of all those things, like your attitude and like everything, SDS appreciate each one of you. Especially, I could see all those names there, and I could tell each from every person, like I could tell all those nice things, like how you have participated. So thank you, thank you, thank you. So.
Okay, there's a couple of questions here, and we have a few minutes left. We have about 20 minutes left, so that's good. Let's go back to, it says, I'm still confused on the ICF to SNF question. Can we answer specifically to that scenario? And I think we were talking about different levels of care at that time.
What did she ask before? What was her question? Kathy.
And we're still here, don't worry, because we're a little bit quiet. We're just scrolling through questions to see. ICF to SNF level of care, and it was when we were talking about when people's level of care might change. They go out and then come back with a different level of care.
So if the ICF level of care, like if the person was in the facility and if anything happened, and there was a critical situation or acute situation and the patient has to go to the hospital and the patient's condition has gone critical, then the ICF level of care will be changed to SNF. So during the time of discharge from the hospital to the nursing home, that ICF criteria, what the patient was on before, could be changed to SNF. So that is the area when the patient comes back, you can send us the form indicating that the patient's ICF criteria has changed to the SNF condition because of the whatever happened to the patient during the time of hospitalization. If that answers your question, I don't know whether you got it, you can ask.
So this is Kara. If I get you right, for example, a person who has ICF level of care is a person who needs care for stable conditions initially, because I was watching the part about the different kinds of level of care. So suppose that person has a life-changing stroke. Then their care is not really so much about the stable condition, it's about this new physical condition, diagnosis, event that has changed what kind of help they need, and that is changing them to SNF level of care. Did I kind of get it right?
Yeah. Right. And that was an example I was considering too. So I could see this person who has been fairly stable all this time, a chronic condition that is stable under ICF level of care. They might have suffered a stroke while they were still in the nursing home. I can see this person going into the hospital, admitted for treatment. Now they're ready to be discharged from the acute care setting, so they may be coming back to the nursing home, but now there's a need for physical therapy, so the need for physical therapy is 5 or more times, per week. There is your change from ICF to SNF to SNF level of care. After however long a period of time the therapies need to be provided, 5 days per week, and they drop down to 3, there is where they can potentially transition back down to an ICF level of care. It really all, we're focusing here on therapies because it's a little more clear cut as to the frequencies and the appropriate level of care. It could also include other needs, the need for the observation, assessment, and treatment, and all of the other needs, based on other comorbidities. The person may be, diabetic and may need insulin, on a sliding scale, or maybe the doc needs to be called every time, a blood sugar is checked. So all of those other factors might play into the change in level of care from ICF to, skilled, or skilled, back down to ICF.
Okay. Other questions. When we were talking about discharges, it says you are talking about administrative discharge versus someone who is admitted for short-term rehab, i.e. joint replacement, who may only be in the facility for 14 to 20 days.
Right.
Yeah.
That's correct.
Right.
We're still, every Thursday, we're still asking that for all of your admissions and discharges during the week, if you can let us know by that Thursday if anything needs to be changed, especially to the work order, because we process our work orders for all the authorizations that we've done by for the week. We do that on Friday, so we would like to have as much information as possible, by that Thursday. So if we have a discharge, like you said, for somebody who comes in the short-term rehab, if they're there for the 20 days, we're planning on discharging them, and we can put that discharge date in our system, so we don't have them still logged as being in your facility.
Okay. Next question is about applying for administrative wait days. When the rules for our system came out, we said that you have to identify a nursing facility that has agreed to take the patient before you can apply for administrative wait days. If there's a delay for when the accepting facility can admit the patient, then you can apply for administrative wait days. Now I'm hearing that you can actually apply for administrative wait days before you have identified an accepting facility willing to take the patient. It's confusing. Can we clarify?
You can apply for administrative wait days when you've identified that you need administrative wait days. You should always have a facility where you're looking to admit to. That's the whole purpose for administrative wait days. They have to kind of sit somewhere and wait, to get into a nursing home, whether the bed is available or not. So the time may, fluctuate anywhere from days to weeks and maybe even a month. But yes, you should always identify a facility that you're looking to admit the person to, or even several facilities. So on your long-term care authorization form, in that section, that's where we look to see what facilities you've listed that are for, there for consideration.
Okay. Thank you, Mobley. Next.
I'm not sure if I quite captured that
Okay.
question, but
if we don't get a chance to fully answer all the questions, it's okay just to write them. It does sometimes happen that we just get questions and we're unable to answer them during the session, because we have them in a report that we can route to the team, and the team can get back with you via email. So don't worry, you don't have to ask all your questions right now today. Of course, you can see on your screen there's resource for questions for later, but certainly if something comes to mind, just go ahead and write it. And if we can't get to it, don't worry, we will address it later on. Okay, question says, recently a care coordinator informed me they could no longer arrange transportation services for patients to and from appointments or medical care. This is a huge barrier for discharge planning from our facility. I can probably give some information about that one. Okay, medical transportation as paid through Medicaid can be arranged by a care coordinator. It can also be arranged by the facility and or the medical office that's scheduling the appointment. Care coordinators are not the only ones that can do that, yet they can request them on a patient's behalf. Medical transportation for medical visits are not waiver services. They're regular Medicaid services. So they're not going to be on a waiver plan of care as a requested service. Yet a care coordinator can still schedule them with Conduent. What is not going to be approved by Conduent are regular checkup type medical visits, such as, you know, checkups based on age or an annual exam, annual dental visit, something like that. The kind of medical appointments that can be approved by Conduent are those that are associated with a course of treatment. So when the ride is scheduled, it needs to be made for an appointment that has a condition the person is experiencing that they need the appointment for, that is part of a course of treatment, not just an annual exam, and also not just no information. We're finding that a lot of times when a care coordinator or somebody else requests these rides, they just don't give the information that Conduent needs in order to approve the ride. If somebody is going for a visit to an oncologist for a cancer screening because they have a history of cancer in their family and they are being monitored for this condition, that is going to be an approvable ride. If the only information that Conduent gets is that it's an oncology visit, they're not going to be able to approve it. It has to be part of an ongoing or new condition or something like that that the visit is for. And that probably wouldn't be really hard to come up with that kind of information for the population that we serve in the scenario that you're describing through discharge. Because people are going to be undergoing treatments, as long as the treatments they make sense with the request for the visit, they're going to the office that does that type of treatment, all those details, again, it comes back to the documentation. So it's not that medical transportation is not able to be arranged, it's that it has to be specifically related to the treatment that the person is getting at the visit. Okay, next question says, let's see, we'll get to the ones that we can. We have about 7 minutes left. Okay, when a complex patient's discharge is held because the waiver assessment for additional home services cannot be scheduled until after discharge, how can we assist families with additional medical needs until a waiver assessment can be completed?
I'm sorry, read that one word.
When a complex patient's discharge is held because the waiver assessment for additional home services cannot be scheduled until after the discharge, how can we assist families with additional medical needs until a waiver assessment can be completed?
So one, there is the nursing transition grant fund that's available that might help to bridge that gap. But I will say we are able to assess in the institution or in the hospital, so long as you provide the information that we are requesting that's on our template that we provided. We're looking for specific information because the applicant may still be in the nursing home or may still be in the hospital. Because the assessments happen there, it's hard for the assessor to, one, gauge what the home looks like, which will impact services that may be approved. So, for example, we assess someone in the nursing home, it's highly accessible. yet the person's actual home may be 2 stories. Their bedroom and bathroom are on the 2nd floor, and the dining and living room may be on the 1st floor. So there's going to be a need for assistance. There may be a need for assistance to go up and down those stairs. We're not going to be able to capture those types of needs when we assess the resident in the nursing home. Some of the other things, will depend on the type of service they're looking for. We may not be able to capture some of the information we will need to gauge from the nursing home, where we would be better able to capture that information if we were assessing in the person's actual home environment. If the discharge disposition is to an ALH rather than the person's home, that changes the perspective of the assessor. So we can assess someone in the nursing home. We just ask that you provide the information we're asking for on our discharge template. But yeah, you feel free to call and ask us questions. We will definitely, I know there are a lot of different situations, whether it's in the community or just for the consumer, the resident alone. We're more than happy to work with anybody to help the resident transition out of the nursing home.
Okay, thank you, Molly. We're at 4 minutes till the end here. Just a few more questions. Again, regarding administrative wait days, what happens if the facility has applied for them and have been approved for them, then the patient goes home? What if the facility has been reimbursed for the administrative wait days, but the patient goes home or dies?
If you've been approved for those administrative wait days, we're still going to take and approve you for them. If they leave against medical advice, or if they expire before they're able to go to the nursing facility, the intention was still to send them to a nursing facility.
Right.
So we would easily still be able to take and authorize that. Or if their treatment, let's say they were, and we've seen this situation too, the intention is to take and release them to a lower level of care in a nursing facility as opposed to being in a hospital, because they only have IV antibiotics for the next, 3 weeks or something along those lines. And you're not able to take and find that nursing facility placement and their treatment concludes while they're there, we would still consider that, something that's approved under the administrative wait day. So there's no difficulty there.
Right.
And then what if the facility's been reimbursed for the administrative wait day, but the patient goes home or dies? They've been reimbursed.
So you bill for 30 days before, and they leave.
Yeah, you shouldn't be billing for 30 days if it hasn't been used yet, I should say. When we provide an authorization based on the anticipated dates you provided on the auth form, those are the dates we're going to give you, but keep in mind, those may not always be the appropriate dates. So if we authorized from 10/1 to 10/31 and the person expired 10/16, you shouldn't have billed for 10/1 to 10/31 before those dates have already passed.
Correct. And this is Kara. Medicaid in general is fee for service, so billing isn't done until after the service is provided. And if there are problems with that, then the agency should have its own methodology to correct its billing. Should they have overbilled or billed differently and anticipated before services were provided, it can be corrected with conduit.
One thing that we do see a lot of overlap with the administrative wait days is whether or not the person is still being considered for Qualis type services, and there might be a little overlap with the authorization while we're considering that discharge. The administrative wait day, the segment that we give you, is approved for 30 days every time. It's a 30-day block. If you don't use all of that block, you don't have to bill for all of it. So we anticipate that you're going to take and bill Medicaid for the services that you provide, as opposed to services that aren't
Billing
there.
for the entire authorized. Right.
Because we once you provide us with that discharge date, be it at an administrative wait bed or not, we reflect that discharge date to on our work orders that go to conduit. So the segment there is for the dates you've provided. So we'll actually end date an authorization that we may have dated previously for a certain number of days. Say 30 days was initially authorized, then you told us, well, they actually discharged after 14 days, then we send that in from that update to conduit on our work order. And also understand that sometimes when we leave those segments open, I mean, this is why we want those discharge dates, that may impact the person being able to use their Medicaid for different types of services, because there's still an open long-term care segment sitting there.
Mm-hmm.
So we like to come back and clean up some of those work order segment approvals so that they reflect appropriately what the person should be, or the facility should be billing for, and then it opens up the consumer for other Medicaid services and the capability of billing for those services or even using those services after. So that's another thing we have to make sure we look at.
Okay.
That's an easy question to answer for Elizabeth Hart for the last one.
All right. We're a little bit over time, but if it's a quick one, that's okay. Last question. I have a LTC admit who's still private pay with a Medicaid application pending. Is it still accurate to wait until Medicaid is approved before submitting the LTC off? I did submit the PASRR prior to admit.
Please wait until you have an active Medicaid authorization number before you send us the long-term care authorization. So just because we can't give you a segment until we have a Medicaid number, if that makes sense. So,
yeah, but your PASRR is on file, so
yeah.
we see that there's.
Okay. Thanks, everybody. We'll go ahead and I don't see any other questions either, so that's good. You can always send your questions and communicate with us via the information on your screen. I want to thank everybody for spending time with us here this morning to learn all about our topic today, long-term care updates. And I want to thank our team for presenting and answering all the questions as well. We'll go ahead and close our session and invite you to go ahead and click out at any time. I'll leave the webinar part awake, but no audio for about a minute or two until everyone leaves. Thanks, everybody, and we'll see you at our next webinar. Bye-bye.